Good afternoon, and thank you for joining us today. I'm McLeod, Executive Director for the Eldercare Foundation, and your MC for this afternoon's presentation. We acknowledge with respect the Lekwungen peoples on whose traditional territory we work, live, and play, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationship with the land continues to this day. As you know, the United Nations International Day of Older Persons and Canada's National Seniors Day are both celebrated today, October 1st. The United Nations Decade on Healthy Aging, which runs from 2021 to 2030, is a global collaboration that brings together governments, organizations, professionals, academics, the private sector, and the media to improve the lives of older individuals, their families, and the communities in which they live. The decade will focus on 4 areas: combating ageism, creating age-friendly environments, ensuring the provision of integrated care, and ensuring the provision of long-term care. The University of Victoria's Institute on Aging and Lifelong Health and the Eldercare Foundation are pleased to present today's lecture featuring panelists Andrew Wister, Jodi Mucha, and Louise Rolland. Building on the UN's theme, today's presentation will focus on the positive aspects of growing older, combating ageism, supporting resilience, and building healthy, age-friendly communities. We hope you enjoy the lecture and take away some valuable insights on this topical theme. Before we begin, a few housekeeping notes for you watching in the audience. Your audio has been muted, and we have set it up so only the presenters and myself will be on video. For best viewing, we recommend that you are on speaker view. This should be the default setting that you've entered the event in. To ensure you're on this setting, or to change your setting to the speaker view, look at the top right corner of your screen and click Speaker View to change it from Gallery View. You can adjust your view of the presentation slides and speaker by moving the bar in the middle of your screen. We are pleased to have Noriko Piquel of Island Deaf and Hard of Hearing with us today, providing live transcription for closed captions. At the bottom of your Zoom screen, you will see a closed caption icon. Click on it to show subtitles. If you'd like to make the subtitles bigger, click Subtitle Settings. Then use the sliding scale to adjust the size of the font so that it's comfortable for you to read. This event is also being recorded and will be posted to the Institute's website and the Eldercare's website following today's live event. Our 3 panelists will each give their presentation, and then we will open the Q&A session. You may ask questions by using the Q&A option at the bottom of your screen. Please click the Q&A icon to open the text box and indicate to whom you are asking your question. And lastly, don't forget to move around and stretch regularly, as we'll be together for a couple of hours. Okay, now that our housekeeping is out of the way, let's get going. I'd like to start by introducing you to our 3 panelists. Dr. Andrew Wister is the Director of Gerontology Research Center and is a professor in the Department of Gerontology at Fraser University. He is also the locally responsible investigator for the Canadian Longitudinal Study on Aging at Fraser University and an affiliate of the Institute on Aging and Lifelong Health at UVic. Dr. Wister is an internationally recognized authority on aging research, issues, and policies. His research interests include the collection and analysis of health and social data, multimorbidity resilience and aging, environmental adaptation among older adults, patterns of family and social support, health promotion and population health, and life course trends and transitions. He is the past chair of the National Seniors Council of Canada and is a fellow of the Gerontological Society of America. He was awarded the Distinguished Member Award from the Canadian Association on Gerontology in 2014 and was the recipient of the prestigious SFU University Professorship Award from 2015 to 2020. He has over 170 publications in addition to numerous books, textbooks, monographs, reports, chapters, and conference presentations. Welcome, Andrew. Jodi Mucha is the Executive Director of BC Healthy Communities. She has a Master's in Environment and Management and over 20 years of community development experience working at both the local and international levels. She has a background in community engagement, organizational and community change, and participatory action research. She provides expertise in multi-sectoral collaboration and partnerships, systems thinking, and the healthy communities approach. Jodi was close to her grandma growing up and has always had a passion for working with seniors. One of her favorite portfolios at BC Healthy Communities is the Age Friendly Communities program, whereby she supports local governments across the province to develop policies, plans, programs, and processes to support the journey of aging. As a hobby, Jodi runs ultra-distance trail races, facilitates leadership courses, and maintains her organic garden. Welcome, Jodi. Louise Rolland is a medicine woman, integrative energy practitioner, end-of-life doula, and health coach who has studied and practiced the art of healing for over 25 years. She is also a program coordinator with Self-Management BC, which offers programs and coaching for those living with chronic conditions. Louise is also a director for the Heart Center Foundation, which provides education and support for anyone who may be experiencing grief and loss. Louise's passion for wellness began when she was a young woman faced with a diagnosis of cancer. She discovered homeopathy, Reiki, quantum touch, chakra therapy, shamanism, and aromatherapy, to mention only a few of the tools she now shares with others. Louise's sole purpose is to encourage, inspire, and share her skills and knowledge with others on their life's journey. Louise currently lives on the Sunshine Coast, and she's developing a retreat, Medicine Bear Gardens, for those wanting to connect with nature, reflect, rejuvenate, or prepare for their final journey home. Welcome, Louise. Now that you know a little bit about our three panelists, I will turn it over to them for their presentations, starting with Andrew.
Thank you very much, Lori. That was a terrific introduction for all of us. I hope what you said about me was mostly true. Welcome, everyone. I'm just going to share my screen, if I may, and start my PowerPoint presentation. I assume you're able to see that. If not, I'm sure Lori or someone will inform me. I'd like to start off by acknowledging that I live, work, and play on the traditional unceded homelands of the Squamish, Musqueam, and Tsleil-Waututh nations. Welcome, everyone. The title of my talk is Resilience in Aging, but I'd like to also, I think partly in recognition of the International Day of Older Persons and in recognition of the theme of today, talk a little bit about ageism. And then I'm going to segue into a talk that focuses a little bit more on resilience. The Decade of Healthy Aging report that was just released indeed has ageism as one of the 4 pillars, along with age-friendly communities, which we'll hear about today, long-term care, and integrated care. Ageism is considered a major threat to healthy aging. It's defined in terms of stereotypes, prejudices, and discrimination on the basis of age. The term ageism has been around quite a long time. It was originally coined by Robert Butler, who I'm sure everybody knows is one of the most famous gerontologists, who wrote the Pulitzer-winning novel Aging in America. And that was, well, that's 50 years plus ago. Ageism can be in a number of different forms, ranging from institutional or systemic aging to more individually based types of ageism. I won't go into all of those types, but we know it's there. We know that it's ingrained in the institutional fabric of society, our various organizations, all the way from the public discourse and media, to even education. It can certainly be a systemic issue. About 80% of older adults experience ageism, but 40% experience it on a more frequent basis, 3 times or more per day. But that's just unbelievable, and maybe it's believable to some people, but it certainly is striking. Reviews of systematic reviews of studies, including 422 studies in one report, established associations between ageism and worse outcomes in a whole spectrum of health areas. So ageism affects how the public perceive older people. It can affect how children perceive and younger generations perceive older people, and it can affect how older people perceive themselves. This can influence their day-to-day behaviors, self-image, self-esteem, and so on and so forth. But this is ageism, and the response to ageism is recognized as a global issue requiring a global response. Without a doubt, the COVID pandemic has exacerbated ageism in a number of ways. I wrote an article, I think it was just the very start of the COVID outbreak in March. I believe it was March or early April of 2020 in the Sun, and that first piece that I was interested in actually addressed ageism during COVID, because we saw how COVID affected older adults. Indeed, about 85 to 90% of deaths were among older adults, especially in long-term care. It's shifted slightly, but it's still very much a gero pandemic in many ways. And certainly the public discourse was not very sympathetic in some realms with respect to older adults, seeing them as even more dependent and problematic, problematizing this aging, such that aging is now shutting down society. It also pitted younger and older generations against each other in some discourse. That's something that I find quite disconcerting. And now I'd like to segue into a more positive kind of response to ageism and the pandemic and other aging-related issues and adversities that face older people today by examining resilience in aging. So there's a couple of definitions I want to share with you. Resilience is the ability to bounce back from adversity. Indeed, it can not only be the bouncing back from adversity, but certainly can also entail a growth, and so even better than what you were before. And I think that's a very positive framework. It's certainly one that I think responds to a number of previous frameworks in gerontology, including successful aging model, which kind of identified people who weren't successful in terms of many types of normal aging processes, such as chronic illness. I'd also like to define one area of resilience that I'll be talking a bit more about today, and that is the multi-morbidity resilience term, and that's the ability to rebound from illness adversity. So resilience thinking has developed considerably in the last decade or two, and we're seeing how it can be very useful as a framework to understand how individuals can respond in different ways, psychologically, socially, in terms of functioning, in terms of brain health, in terms of social engagement, in a number of ways. But it is specific in that you have to rebound from some kind of an adversity. Of course, adversity comes in many different forms, not only multimorbidity, which I'll speak to in just a second, but also, well, the pandemic, for instance, other aging-related transitions that take place, including retirement, widowhood, other types of loss that people experience, economic adversities, social isolation, and so on and so forth. Multiple concurrent conditions that are slow in progression and long in duration and episodic are the fundamental characteristics of multimorbidity. They can be, the multimorbidities can be synergetic. In other words, they're more than the sum of the parts. There can be physical challenges, episodic pain or chronic pain, loss of function, loss of independence, and even mortality. And of course, there's social psychological outcomes of multimorbidity, stress, anxiety, depression, loneliness, etc., which we know about. About 60 or so % of people aged 65 to 74 have multimorbidity. About 90% of older adults 65 and over have one chronic illness, one or more. So that's quite common. It's the majority of people, but that can range from a mild level of arthritis or some asthma or some, a number of other chronic illnesses. It doesn't mean necessarily a serious one, albeit asthma can be serious. And arthritis can be serious, but mild probably not so much. But you can see there's about 30 chronic illnesses, so we have to be careful. About 75% of those, 75 to 84, experience multimorbidity, and about a little over 80%, 85 and over. So why do some people, the question that I've been grappling with for some time is, why do some people live well in the face of multimorbidity and others do not? And I think what's really useful about a resilience framework is we're looking at a strength-based approach. We're looking at what are the things that assist people to overcome adversity, and then strengthen those. That's not to say there aren't individuals who are disadvantaged, who experience intersectionality of disadvantage and lack of privilege with respect to socioeconomic status, health, gender, sexual orientation, indigenous status, etc. All of those certainly are there, but this takes us down a different path, and I think it's a useful one. It's not the only one. So why do some people seem to excel better than others? Certainly it could be past experience, perhaps an innate ability or trait that some people have, an attitude, a positive attitude. Maybe it's cultural capital. They're connected to a culture that provides support and the kinds of resources required to bounce back. Perhaps system level, personal resources, or lifestyle behaviors. And I'm going to focus on this last one today, albeit we could focus on many different things. So I think multimorbidity resilience offers an opportunity to examine this form of adversity and see why people can cope, and in some instances even thrive and grow. And when we combine that with the COVID pandemic, I think this provides a very interesting context and an informative context for us to learn more about resilience. So obviously, multimorbidity resilience involves multidimensional processes. So a resilience framing of that requires an approach that's going to be multidimensional. I've come up with, in one of my publications, a life course model of multimorbidity resilience. If you look around the top of this model, you'll see that there's an adverse life event, and that creates some perception of stress. The stress can result in disruption of the individual, and there can be then a movement into the activation of the resources. These resources can be individual, social, environmental resources. I'm sure there's many others. That kind of captures where those are. In order to harness those resources, though, we have to have understanding of them, access to them, and so on and so forth. Then there's some coping processes that result in kind of this reintegration of the self and other components of one's life, and this then can lead to wellness, recovery, and growth. This is more of an individual social psychological model with some embedded social ecological resources. I've since expanded this to more of a system model. And in the system model, I'm combining many of the components in the middle that you just heard about, but adding some resilient system functions from systems theory, the ability of societies to plan, absorb, recover, and adapt. That's very important with COVID, because we've seen, for example, in long-term care, an exposure of fissures in the system, and partly due to the inability to work through those. And then the socio-ecological context, obviously very important. I've talked about many of these, but we got to go beyond the individual. And then there's environmental resilience domains. So resilience kind of comes through in these main ones: physical resilience, informational, cognitive, and social. Physical can be genetic, can be various kinds of functionality, physiology, et cetera. And then at the bottom, this all occurs over an individual's life course. We have to take into account the life course. The Canadian Longitudinal Study of Aging is a very large national cohort study in which we're following over 51,000 individuals starting back in 2012 for 20 years. Every 3 years, the same people are interviewed. There's a tracking cohort, which is a telephone interview, and then a comprehensive cohort in which we're collecting data all the way from blood work for genetic research, all the way up, including the telephone component as well, but physiological data, bone density, et cetera, et cetera. And I'm going to present some data that was initial data from the first wave and some on the second wave, so the baseline of first wave. And I'd like to start by just talking a little bit about an index that I created from these data, a functional resilience index, which used the OR's functional status, IADL, ADLs, which everyone knows about. This Rolland is basically a functional score based on a number of balance and gait and get up and go kinds of tests, which people have probably heard about, and it's a physical measure. Social resilience, the MOS, is a famous scale that picks up on emotional support, instrumental support, a whole range of types of support. And then I included participation and a loneliness measure. And then psychological resilience, the Kessler Psychological Distress Scale was available in CLSA, it was used, and a satisfaction with life, a life satisfaction scale, a famous Diener one, and also famous, the CESD depression scale. So these are all established measures. And so I combined them into an index. I won't get into all the details of that, but it has these three sub-indexes. And then my interest was to see, how does the resilience, how is it associated with various lifestyle or behavioral factors? Because these are mutable or changeable kinds of behaviors, things that we could develop interventions around and certainly encourage people to engage in. And I think this is very relevant for not only multimorbidity, adversity, resilience, but all kinds of resilience. Nevertheless, this study examined multimorbidity resilience as was defined. So we found that the main associations in terms of lifestyle were normal or underweight versus BMI versus overweight and obese, having better sleep, obviously extremely important, and there's more literature on that coming out in many areas. Better appetite, fewer skip meals, not smoking and less activity. There were about 20 variables altogether. So these are the ones that surfaced for the lifestyle behavior ones. Of course, being female, younger senior, married, more friends, fewer housing problems were also associated with higher resilience scores, higher multimorbidity index scores, higher perceived health and less pain as well. So these are interesting and important, and I think it points in a direction of where we can, some of the low-hanging fruit that might be useful to focus on for behavioral change in whatever form that may take. There was also the question that I raised about whether there's multimorbidity disease clusters, because the multimorbidity work that I did, that I just showed you, was anyone with 2 or more chronic illnesses. That blends a lot of different people together. And so I looked at an osteo cluster, people with 2 or more of these: osteoarthritis, osteoporosis, lung disease, back problems, metabolic, vascular, diabetes, hypertension, heart disease. I'm reading through these quickly. Mental health clusters, anxiety, mood disorder, migraine, headaches. These are the ones that were available. So I'm looking specifically at these 3 clusters. With respect to the osteo and cardiovascular ones, it really replicated the findings I showed you earlier, almost exactly. But the mental health cluster was distinct. There were 7 differences. It was not associated with being married among the mental health cluster, that is multimorbidity resilience, or having more friends, obesity, smoking, or appetite. It was related to inactivity. Sleep satisfaction was very strong for the mental health cluster. So looking forward, I think there's a lot of unexplored territory. I'm engaged now in some work using the CLSA COVID survey. So during COVID, we had to slow down our normal cycle of collecting CLSA data. We were in the 3rd wave, what we call a follow-up 2, and it was necessary to stop the face-to-face kinds of data collection. We could continue the tracking and change some of the face-to-face interviews to phone-based. But it allowed us also an opportunity to develop and find funding through PHAC, a COVID study. And this is based on about a 25-minute phone or internet-based fillable questionnaire about COVID, about a number of aspects of COVID, including social isolation, multimorbidity, caregiving, etc. So I've been engaged in some work on multimorbidity resilience, and that work is ongoing now, as well as caregiving during COVID. But the caregiving, that one's submitted, and the findings there showed that caregiving was also exacerbated, probably not surprising, but there were some interesting components of the caregiving situation that seem to surface that are unique to the pandemic. I won't speak to that today, but there's lots of things percolating. I encourage people to look into the CLSA. It's a wonderful resource for examining a number of issues. Needless to say, you need to combine other types of data collection. So indeed, I've submitted a recent grant to engage in some resilience research that combines a qualitative data collection with CLSA data in a multi-method study. I'm examining multimorbidity resilience as well as social isolation and loneliness and the effects of the pandemic on these very important areas. So going forward, just some final thoughts. We need some more studies in this area. We certainly need to examine system level resilience, as I've alluded to, and certainly research into multimorbidity resilience and recovery from the pandemic in the areas I've mentioned. And these, I think, can help us to understand areas where we can strengthen people's resolve. Needless to say that there are people with distinct disadvantages, but even people with disadvantages have some strengths, and we need to combine various kinds of approaches. Thank you very much.
Thanks so much, Andrew. I'm Jodi Mucha, Executive Director of BC Healthy Communities. My slides are just being loaded. Thank you so much. Leah, I'm not sure if you can see. Yeah, there we go. Thanks. Excellent. Yeah, next slide. Thanks so much. All right. So as I said, I'm Jodi Mucha, Executive Director of BC Healthy Communities. I'm pleased to be here today to share with you a little about our work and how we support the aging journey through the various programs and projects that we deliver through our organization. I wanted to start with this slide. This is Iris Apfel, and she's a well-known fashion icon. Obviously, you can see by the amazing outfit and jewelry that she's wearing. She turned 100 this August 2021. And I included this quote here: "What's wrong with being 72 or 82 or 92? If God is good enough to give you those years, flaunt them." And I included this just to be a little tongue-in-cheek, because what I'm really here to talk about is that it's not just about what you were born with. And I'm going to build on some of the research and the presentation that Andrew just shared, and focus more specifically on it's the environment and the conditions that you are living in, and how we together are able to create those conditions for everyone to thrive, especially throughout the aging journey. So hence, we're in this together. So next slide, please. So we talk about the social determinants of health, and what those are they're the environmental conditions in which we live our lives. It's where we're born, where we grow, learn, play, work, and where we grow older. And contrary to popular belief, our lifestyle choices actually determine a surprisingly small part of our health. But while about 75% of our health outcomes, including the social, physical, mental health, and mental well-being, those are strongly affected by the social determinants of health. And for example, these include the social factors such as gender, race, employment, working conditions, income, and housing. And it's important for us to be aware of the fact that these factors that affect our health so strongly, they're often beyond our control. And so while the social determinants of health are complex and they intersect with each other, we can apply an equity lens to the policies that we develop, the programs that we design, and the planning that takes place, so that we're able to actually improve those social determinants of health and thus reduce the health inequities. And these impact especially those along the later years of their aging journey. So we can go to the next slide. So just a quick bit about BC Healthy Communities. We have been around since 2005. We're based on the World Health Organization's Healthy Communities, Healthy Cities approach. And critical to our work is an equity lens, which really means you are looking at ensuring and planning that no one is left out, that we're creating environments for everyone to thrive. And for us to do that, we work closely with a range of different sectors, including local governments, Indigenous governments, health authorities, and community organizations. So we go to the next slide. The first example that I'm going to provide is the role that local government can play in planning our communities and initiatives, and hence developing policies that can support the aging, can and do support the aging journey. So local governments, they have the ability to create policies, programs, and partnerships that support overall community health and well-being. And they ensure that processes that they use to establish these policies, programs, and partnerships are inclusive and are equitable. And local governments play a role in establishing the systems that we live in within the local, at the local level. So through our Healthy Communities and our age-friendly work at BC Healthy Communities, we help to bring together leaders from local, municipal, and Indigenous government, together with leaders from the health sector, which includes regional health authorities and First Nations Health Authority. And we help them to bridge the gap between the various groups. And we also ensure that the voices of local champions and organizations are brought to the table. So if we could go to the next slide. So since 2015, BC Healthy Communities has been working in close partnership with local and Indigenous governments to support age-friendly capacity building. And what that is that we're supporting planning for age-friendly communities and ensuring that no one gets left out and that plans are developed to support everyone. And I mean, an inclusive, age-friendly, and healthy community means that it's kind of the 8 to 80 concept. If it's good for older adults, it's also going to be good for youth. And my first example today of how we're in this together and the role that local governments can play is specific to Abbotsford as a municipal government and what they've done specifically to support age-friendly planning at the local level. So we can go to the next slide, please. So Abbotsford is known as the city in the country, and they're surrounded by agricultural land, which is really the anchor of the economy there. The population is 147,000, and it's the 5th largest city in BC. Approximately 37% of the population is between the age of 50 and older. So in 2017, Abbotsford received funding through the Union of BC Municipalities, and they established an age-friendly advisory committee where they conducted an age-friendly assessment, and they published this report. That's the image that's showing on the slide there. And for the age-friendly work that they've done with us recently with BC Healthy Communities, they wanted to build on the foundation of the work they did in 2017 and take a more coordinated approach. So they wanted to build on a program that they had in place, which is the Abbotsford Coordinated Intake and Referral System. And that was specifically for those who are experiencing homelessness and are at the risk of homelessness. And so this community invested resource provides access to housing, health, income assistance, and support connections through a number of initiatives and programs. So Abbotsford was taking on this very large scale systems change effort across social issues to address the key challenges that they are experiencing in their municipality. And they wanted to strengthen the alignment of the Abbotsford homelessness prevention and system and link it to their age-friendly needs assessment and their planning document that they developed in 2017. And their aim overall was to develop targeted strategies that would improve local response to the vulnerable and isolated older adults that specifically were experiencing homelessness. And what they were doing is looking to determine the gaps in the services for this group of older adults in their community. And so BC Healthy Communities worked with them through their planning process, and with their lead contact at the city, who was very much at the forefront of this work. Their vision and their commitment was to ensuring that they were applying an equity lens to all of the work that they were moving forward on, and applying it in the community level work with the community organizations that they were partnering with. So they have an advisory committee of 47 different organizations. So BC Healthy Communities came in and worked with them over a period of months to design an equity training that was delivered to this advisory group that consisted of the 47 different partners. And so this was, ideally it would have been in person, but obviously because of COVID, we had to deliver it online. And so what we did was we designed this equity curriculum, this training for the advisory committee, but it was really meant for the advisory committee to then take that learning and almost use it as a the trainer approach to then work with their respective organizations and staff. So there was a ripple effect of the use of this equity lens to understand how to better plan all the different activities moving forward. And we were really looking at the intersection between older adults and older adults that were experiencing homelessness. And we call this intersectionality, when you realize that people are never really from just one group, such as gender or race. And you need to take that into consideration. So commonly referred to as intersectionality. And I'll give you something to consider. So considering two descriptions of a person that I'll share, and how the differences in those descriptions might impact the questions you would want to ask or the actions you would want to provide to support that person. So in the first example, let's just say you receive information about a woman who is 55 years old and she's experiencing homelessness. So you might think of a few different strategies that you may want to embark on to support her. And then in the second description, just imagine you receive information about this woman who she's single, she's 67 years old, she's an Indigenous woman, she's living with a disability, and she is experiencing homelessness. So it gives you a lot more context, and it opens up dialogue around how specifically can you address this issue for this individual or folks that are experiencing the range of different complex issues. So, you know, there's a quote by Einstein that it's insanity to try to fix the solution, fix the problem with the same solution. And so you really have to start asking a lot of questions to get to the heart of the matter so that you can provide customized supports. And this is exactly what Abbotsford has embarked on. So we delivered the equity training and provided curated resources and trained the trainer support information for the advisory group members who participated in the training, for them to work with their local communities. And they're still working on their plans at this point in time, but we really commend the City of Abbotsford for their vision, their commitment, and the activities that they're taking to ensure that they really are being inclusive, and looking at very practical applications for how to address homelessness within the older adult population in Abbotsford. So the next slide, please. I'm going to give you a second example. You can go to the next slide. And this one, I just absolutely love this project. This was when I got to meet Lori McLeod from the Eldercare Foundation, and it was the first time that we worked together. It was in response to some research that had been done in Victoria, the Greater Victoria area, and outlying areas, that the results showed that in this one particular community, the Gorge Tillicum neighborhood in particular, it was around inclusion and diversity. And it really showed that there was a big gap between between the connection between youth and seniors or older adults. And so we came together, BC Healthy Communities, the Eldercare Foundation, and the Yakimovich Wellness Center, along with Saanich Parks and Recreation. And we wrote an application to receive some funding to embark on working with the Gorge Tillicum, a group in Gorge Tillicum, to do some research and address this issue. And so the initiative started out being called Trust Me, and it was meant to bring together older adults and youth to come together to have conversations about what the differences were and what the commonalities were between older adults and youth. And we facilitated these sessions over a period of several months, and there were 8 youth and 8 older adults that committed to participating in this project for that period of time. And what they found was that there were a lot more differences, a lot more similarities than differences, which they were actually surprised about. And what they found was, you know, we all feel nervous when we're talking to someone from a different age group. We all want to connect more in the community and be more connected at an intergenerational level. I do feel nervous when I'm walking past a group of youth in hoodies, or I do feel nervous when I'm passing someone in a wheelchair on the street. And so the idea behind the project was that they would identify projects in their community that they could create to have the community be more inclusive. And in the end, what happened was they agreed that they only wanted to work on one project. And so they did a lot of work. They also stood up and said, this name, Trust Me, just doesn't make sense, because this project is really about trust us. And so a couple of the older adults and a few of the youth got together and designed the Trust Us logo and the imagery for it, so that we would have our own brand. And we got t-shirts made up, which they proudly wore. And then they also identified that there was a space in the Gorge Tillicum area that wasn't really being used to the greatest ability. And they developed an intergenerational garden guide with ideas for how they could have a space that was intergenerational, where older adults and youth could come together and connect and learn from each other, learn with and from each other. And so it was really interesting, because often what we saw during the facilitated sessions that we were leading with the older adults and the youth was that the older adults were actually learning more from the youth. So an example was one of the young girls was knitting every time we were having sessions. She was knitting mitts and toques. And one of the older adults who really connected with her, she said, you know, I've never learned how to knit. Could you teach me how to knit? And so the two of them would get together outside of the time of these sessions. And the young girl was teaching the older adult how to knit, which I thought was pretty cool. And the other thing that it allowed for is some of those older adults who either don't have grandchildren or have grandchildren that are on the East Coast or far away and they don't get to connect. They had the opportunity to connect with some of these young people, and the same thing for the young people. They had now mentors and older adults that could act almost as grandparents to them. So it was a very successful project that's had a ripple effect for several years. It's still going strong in terms of the activities and offerings at the Perks Rec Center that supports that work. So my last example, number 3 on the next slide, slide after that one, thank you, is about local champions. Now, if you go to the next slide, please. There's a small group of, a small cluster of communities on the east shore of Kootenay Lake, and that is halfway between Creston, and then on the opposite side of the lake is Nelson, BC. And these small communities are over a period of 80 kilometers. The aggregate population is approximately 1,000 people. And these communities are known as Riondell, Crawford Bay, Grey Creek, and Boswell. 59% of the people that live there are over 55, and that is far above the national average. So approximately 600 of those folks living there are in their senior years. So they not only developed an age-friendly assessment and age-friendly plan, but they also were able to leverage funds to buy their own bus, an old bus that they could use to address the transportation issues there, the lack of transportation. And they're using that bus for seniors to go to recreational opportunities, to go to Creston for their appointments, and to just access resources that they haven't been able to access because of the lack of transportation due to these rural communities. It's the first time that all 4 communities have gotten together to work together to address aging and age-friendly issues. And they've also, in the last several months, received additional funding to do an age-friendly assessment to identify housing needs and further transportation issues so that they can put some additional plans in place. So those are 3 examples of how a municipality, community organizations, and then very grassroots small communities coming together illustrate that we are all in this together, and it's not any one organization or level of government that is meant to address the challenges that we're facing in communities. But if we take that top-down, bottom-up approach, we together can create conditions for everyone to thrive and hopefully all live to the ripe age of 100, like that fabulous Iris Aptheth with her wonderful, vibrant outfits. So for now, I will hand it back over, and Louise will do her presentation for you.
Information that just builds on what I'm going to share with you. So hello, everyone. Truly, today is a day to celebrate. Older adults are said to be the intellectual capital of our country, representing our foundation of knowledge and experience. So seniors are our mentors, coaches, and guides for all of our communities. Elders in Indigenous communities are respected. They're knowledge keepers and storytellers. Their teachings, their wisdom, and healing are all relevant today in all our communities. whichever name we use, older adults, elders, seniors, they're all our leaders. So I'm really, really pleased to share with you now what it is like for aging in rural communities. So rural communities, let's see, I have lived on the Sunshine Coast now for over 40 years, which is truly a rural community where you can't get to it by car. You have to come by ferry boat or plane. And it's been such a growth on the Sunshine Coast recently. And I can tell you that the senior population has been growing. Of course, you know, the people that have come, they age, but a lot of the families that they came to raise have moved away and gone back to the cities for education, to marry, to travel to somewhere else, to work. Their careers have taken them elsewhere. And so our aging population has grown, and it's amazing how in a smaller rural community, the best way that people communicate is actually word of mouth. So you know, when I first came here, everyone knew each other. We checked in if we hadn't heard from who was, you know, who was supposed to be at a social gathering, say, we would all check in. And that's changed quite a bit now, because especially during this COVID time, where people are now able to work remotely. So I've noticed so many people coming up and building now. They're starting to come and they want to work in rural areas. They want to get away from the hustle bustle of the cities. So the rural areas are starting to expand in my area anyway, and some of the other areas in BC that I know of as well. So we work very closely with all of what Andrew was talking about, is all the government and the research, and we're really anxious and excited to work with that, to see and hear our voices being heard. You know, the communities that and the projects that Jodi spoke about is amazing. It's really made a big difference in our communities that I know of, and I'm sure others, and I didn't know about Abbotsford, so that's wonderful. Good work, Jodi. So the Ministry of Health had a framework of for seniors, and it was healthy aging through healthy living. And the key priority areas which I worked on with seniors group, that it was a seniors advisory group, and at that table was the municipal government. There were the mayors, there were Vancouver Coastal Health, you know, so the health authorities were at that table, the RCMP, the policing, ambulance, you know, all parties were at that table, which was amazing, because the work that we spoke about and we heard what was important to others and the seniors in our communities, we were able to get things done together. We weren't isolated, and the seniors started to become more and more activated at that table. Yeah, so the things that were talked about was, for example, there were no sidewalks. There were no transportation. We didn't have buses. We didn't have, you know, but this organization got together and they started working. And now throughout the whole province, this is happening. This is where all the people are sitting at the table at the same time, hearing what's necessary, tapping into the projects that Jodi's talking about, tapping into the research that Andrew's talking about. And it really has made a difference for their environment. It's safer now. We actually have street lights now, whereas in a lot of the rural communities, they never had such a thing, right? There was no community centers. There was no recreation centers. It was people visiting each other, but everybody knew each other. So the healthy aging, the priority areas were healthy eating, injury prevention, physical activity. There was a tobacco cessation project that was started. There was social connectedness, and it was amazing. The goal was to move toward a more sustainable health system focused on prevention to reduce overcrowded hospitals and wait lists. So if we can go to the next. So these are the things that were talked at the table. We talked about the support. How do people get support that are isolated? The health system, you know, the changes that were being made. How do we roll them out? This is the biggest roadblock that I myself personally, in the work that I do, and not just my communities, but in general, with the work that I do with Self-Management BC. I'm the program coordinator there for all the Vancouver Coastal Health Region, Sea to Sky, Sunshine Coast, Powell River. And, you know, how do we get the information to everybody? So this is something that I'm very passionate about. And this is one of the reasons why I was so excited to be able to share this information with all of you. So one of the things that started to happen to get people, you know, getting the information out were talks like this. We would, the hospital in Seashell, for example, would hold med talks, and people would come and hear about what was happening in the, you know, Vancouver Coastal Health Region, what was going on there. And so other communities started doing the same. So the age-friendly rural community initiative, which was modeled from the World Health Authority, I believe, was where they wanted to look at outdoor spaces, as I had said, with the sidewalks. And so all of that started coming together where, is it safe for them to go? A lot of the seniors have walkers. They couldn't walk on the streets. It's not safe. There was no street lights. So all of this has changed. And this is so exciting for us because we're actually being heard, one thing, but the things are actually that was being asked for has actually been put in place. So this is a positive thing for rural communities that the government is hearing. Research is being done. And the work that I do is actually the part where people, I work mostly with smaller groups of people. And the people that I work with are people that are grieving. They feel lost. They may feel overcome, helpless with health conditions that have been they've been dealing with for a long time. I work with people who are at end of life of their time here. I work with their families. And so I personally feel that when we can get them into a nice, safe environment with social programs available for them, it makes that process a lot better for them to know that they're heard. As I've said many times, that's really important for these people, and that they're cared for. The program ACEs is something that I work with, and so I like to educate people how early childhood adverse experiences may be the root of some of the belief systems that they have acquired. And the research shows that with this research, ACEs, that something like 80-something% of people grow older and experience chronic health conditions. So this is an area that I'm really hoping that we can get more work done and help people realize that they can change that belief system. Dr. Bruce Lipton, he talks about this new science, epigenetics, where the book that he wrote is about being able to change the belief systems that we have. And people get better. They start to come alive when they start to feel like they have, I guess, they have the opportunity. They've got that power. They've got that self-efficacy. It's huge. And when people start to feel that in the support that they have, they've got a house, the basic line of the Maslow's pyramid, where it's food and shelter, when that is taken care of, and their health becomes better. It's not always a cure, but they're better able to manage. And there's been a lot of research around the work that I've been doing. There was a time that I didn't really speak too loudly about doing, Reiki or chakra therapy, where energy work. And I was so excited when I heard that Langara had a program, Advanced Integrative Energy Work. I brought it right back to my community right away, of all the people I knew. And I started sharing that with the people who were on medications, or they may have had cancer. Let's work at this. Let's try and see if it works for you. And it was amazing, the outcome that these people felt in their life. This is my passion, and this is what I really see that knits all of what we've been talking together. And it's really happening quite a bit in the rural areas where, for example, if there's an emergency on the Sunshine Coast, or if there's, somebody really needs heart, surgery up north, they're flowing down into Vancouver to have that surgery from the heart specialists at St. Paul's. If you're in a car accident or have a major stroke here on the Sunshine Coast, our hospital can keep you comfortable until a helicopter comes in and takes us to hospitals in the city. This is great, but we really need to fill in the gaps. People with chronic health conditions or whatever, conditions, acute, as well as chronic health condition, if we can fill in that gap of what do they do while the doctors are doing the surgery, when the healing starts to take place, when they can start, their mental health starts to come back, the depression dissipates somewhat. All of these things that happen when we get the person all the resources that they need to be complete, to be whole. Living in a rural community, it's utmost important, and we have so many healers, we have so many, there's so many healers and so many people that are sharing this information all through the province, all through Canada now. I'm starting to notice it's becoming a real, it's a real thing. It's not something that I want to be quiet about anymore. We used to be called woo-woo, but now it's not woo-woo. There are researchers that are working on it, and it has really helped in the people's of rural areas of all communities in their well-being. So one of the resources that I really want to share with you is in BC, we have this amazing work that I work with the BC Paramedic Community Paramedics Program. They bridge their health services gaps with local health services in their area. And there's 99 BC communities that are covered with this program through BC. It's an amazing program. They meet with people and, just to see how are they doing, how is, and with the COVID, the thing that's happening with this pandemic, they're still able to connect with these people, checking in with them. And I just want to say, even with this pandemic, I am so impressed with all the work that everybody's still continuing to do, all the workarounds. We've been so creative, haven't we? It's just been amazing. But back to the paramedic program, they work very closely with us as well at Self Management BC in that they share our programs and tell others, all the people that they're meeting, their patients and clients, of our programs, which is really so important that we all work together. Okay. Okay. Okay, so the other one too is better at home. The community with seniors, you know, they want to stay, seniors or older or whatever you want, whatever word you want to say, the aging community wants to stay in their home. What's preventing them and what's causing issues with them having the ability to stay in their home is what Better at Homes helps them with, and that's grocery shopping. It helps them with friendly visiting, transportation, light housework, even yard work, and minor home repairs. In the winter, they'll send somebody to snow shovel. This is an amazing program for aging community, aging people who want to stay in their homes and longer, and this is really so beneficial as well. There are more and more facilities being built for assisted living in various communities, but it's utmost important for people to be able to stay in their home. It helps them mentally, physically, and emotionally as well, and to get the help, that support. There's also BC palliative care benefits. Now they support any age, but definitely anyone who has reached end stage of life, they will help with palliative care in their homes. So that is something that's really important. A lot of the aging, people, community on the coast really feel like they want to stay at home. They don't want to go and be apart from them. They want to stay where they're comfortable. And so this program really helps make that real. So we've got amazing support with home support. The aging community in our rural areas are supported with this service as well. If they've had surgery and are sent home and they have no one to check in on them, there's somebody that comes and helps them with their medication, that will help them with looking at the wounds, whatever it is that a patient needs as far as their health care. The home support workers are great. Okay, so I'd like to talk a little bit now about our programs on the next slide, which is with the self-management programs that I am employed with. We're with the University of Victoria Institute on Aging and Lifelong Health. We're funded by the Ministry of Health, and the research that we do has shown that people who attend our workshops have so many wonderful testimonies that come back and say, this program was great. And in this program, self-efficacy is the most important aspect. I have testimonies where we have had people attend our programs that say it's changed their lives. The programs, the research has shown our programs are attended mostly by older adults. Okay. And so a lot of the things that were shared in our programs are problem solving, decision making, communication with your healthcare providers, all of making action plans, small action plans, taking little steps at a time builds that self-efficacy. It also yeah, so what I wanted to share was that the programs we have amazing toolkits that if anybody is interested, please contact me, because you'd be able to receive these toolkits for chronic conditions, chronic pain, and diabetes. We also have a Cancer Thriving and Surviving program. We have an online program and an excellent health coach program. So please, if you want to know any more information about these programs, give me a call and I'd be happy to send you some more information. And we had one doctor send in a letter saying he had a patient come to the programs, an elderly woman who really did amazing with her condition. And he asked her, what was the difference and what did she do differently? And she shared that she had attended this program and she had our Living a Healthy Life book. He was so interested. He signed up for one of our workshops. We didn't know who he was. He didn't say that he was a healthcare provider. And he was so amazed at the work that was done in this program. So he is now sharing it with other healthcare providers because he says it helps them do their work better. So I really want to thank you all for hearing all of this work that is so important, not just in all communities, but aging in a rural community. These resources are so important, and so are all the ones that Andrew and Jodi that are working on as well. So I want to thank you so much.
Thank you very much, Louise, and thank you to Andrew and Jodi as well. Very informative and thought-provoking presentations. Lots of great food for thought, and hopefully some great questions too. I see some questions up there. So I hope you stretch. Don't worry, we're not going to be here for 2 more hours. We're going to try to end close on time. It doesn't give us a lot of time for questions, but we'll take 2 or 3 questions anyways. So the first question is for Andrew. Do you think COVID-19 will be seen as a pandemic for all ages, or do you think it will still be seen as an event that has primarily had an impact on seniors?
I think both. The answer is both. I mean, indeed, this is a very intelligent disease. It's an infection that's able to transform itself into new variants. It's going to be likely around for a long time, unless we can all get vaccinated. And it's affecting now children. It's jumping around different age groups, different communities, different countries. So it certainly is a pandemic. Pan. It's global and all populations. However, without a doubt, it has affected older adults more than other groups. And this isn't really different than other kinds of major crises and environmental threats and so forth, whether it's, hurricanes, heat waves, fires, Katrina. You think about how, the death toll was primarily older adults, many of whom were in long-term care. So yes, it's still a gero pandemic as well.
Great, thank you. Jodi, this one's for you. Could you please clarify the distinction between a healthy community and an age-friendly community? Are age-friendly communities focused primarily on those 65 and older, or are they communities that meet the needs of everyone, regardless of chronological age?
Thanks for that question, Laurie. While it is called age-friendly communities, the concept is really focused around planning based on 8 domains. So thinking about outdoor spaces, transportation, housing, etc. And anything that you do to plan for and put in place for age-friendly communities, it definitely benefits the whole spectrum of ages. Quite honestly, I think the World Health Organization kept it contained as age-friendly communities to have it be focused, but it really is more of that, I mentioned in my presentation, an 8 to 80 approach. And then I think the distinction between healthy communities and age-friendly communities is not that they're really that much different. However, the healthy communities approach is exactly that. It's an approach, it's a lens. So to have a community be a healthy community, we're building on the 5 pillars of how to go about that. So ensuring that you have political commitment. So you've got the local municipal leaders at the table. You've got community members at the table. You're working with multi-sectoral groups. You are taking an asset-based approach, and you're informing and developing healthy public policies. So healthy communities approach it's just that, it's essentially a process, whereas age-friendly communities, there's the 8 domains that you can go to work on addressing to create conditions for, yes, older adults, and bus shelters that are well lit, sidewalks that are wide enough are obviously good for everyone in the community. So hope that gives a little bit of clarity. It's like they say in Thailand, same, but different.
That's where that came from. I use that all the time. I didn't know that. Here's one for you, Louise. Someone wants to know if there is anyone like you in the Vancouver area. One of the participants was seeing someone, but that person is no longer there. And they were just wondering if you know of how to get a hold of folks that have your wellness background.
I do know some people. I would need to speak with this person more to see what specific, help that they want.
Well, perhaps we can take that one offline, and
Okay.
we can get you in touch with the person who asked the question.
That would be beautiful. That would be great. Thank you. Yeah.
So Jodi, we all know that social determinants of health are influencing everything: health, education, employment, happiness. Are you aware of any evidence that addresses how immigration affects healthy aging? And Andrew, you might have something to add to that too.
That's a really good question. I do not actually, off the top of my head, have specific documents or research that I could point to. I suspect, Andrew, I'm not sure if you may, but I mean, yes, definitely there is. We did several years ago a lot of work around inclusion and diversity, specifically in the Lower Mainland with immigrant and newcomers. And again, it was intergenerational focused. So we were looking at some of the data, and it really was more around that sense of isolation. So it was around inclusion, social connectedness, and the barriers to that. But I will pass the baton over to Andrew if you have any further comments that you can make to this question.
Thanks, Jodi. There's at least 2 major bodies of research and knowledge. One is around the healthy immigrant effect, which fundamentally shows that immigration, older adults or even middle-aged adults who come to Canada and age in Canada, there's a selection effect at first because we tend to pick more healthy people to come into Canada, weed others out, and then over time they start to mirror the general population. So in fact their health declines and is very close to what the average is, and that's just at a population-based area level. There's a large body of literature though that focuses on immigrants who, especially visible minorities, we know immigration patterns have changed. The countries of origin are now Asian countries, African countries, South American countries, so on and so forth. We have a lot more visible minorities. We have a lot more people with challenges with respect to language and other cultural and social class barriers, which intersect in an intersectionality framework together to create a disadvantage. So a lot of that work looks at, examines especially language barriers and cultural barriers to utilizing healthcare services. So even though we have, a healthcare system that's supposed to be fair and equal and universal, it actually isn't. for a lot of people. And indeed, you know, new immigrants have to wait for a period of time before they can access various services and so on and so forth. So, I mean, we're getting better. I think one area that's really problematic is mental health services, but I won't speak to that right now. Thank you.
Mm-hmm.
Thank you, Andrew. And I just got the hi sign. We do have a lot more questions in the queue, but unfortunately we're running short on time, and I promised we'd get you out of here before 2 hours. There's one more question and I can answer that one just in time. There was a participant who has many chronic health conditions and is in pain, and he's burnt out because he is caregiving for his aging parents, and he wants to know if there's any resources out there. Yes, there are. Family Caregivers of BC are fantastic. You can Google Family Caregivers of BC. They have online help, they have webinars, and you can just give them a call and they are happy to help you. It's a fantastic resource. So I hope that helps. I'm sorry that there's no more time for questions. That was a fantastic presentation. Thank you very much to our speakers today, Andrew Wister, Jodi Mucha, and Louise Rolland, for sharing their knowledge and expertise. I know the information was fantastic for both my work life and my personal life, and I hope that you got some valuable information that's going to help you today too. I also want to give a special shout out to our organizing and technical team from the Institute for overseeing this year's event and making sure that everything ran smoothly, which it did. Thank you, Leah, Joanne, and Ashley. And also a shout out to Noriko. Thank you for your live transcription. On behalf of the Eldercare Foundation and the UVic Institute on Aging and Lifelong Health, we thank all of you in our audience today for attending our lecture in celebration of International Day of Older Persons and this decade of healthy aging. I hope you all learned something today that will benefit you or someone in your life. There are resources that will be included in the exit slide that you'll see in a moment, as well as links to organizations and to the recording. Today's session, as I mentioned earlier, was recorded, and it will be online on both the Eldercare website and the Institute's website following this live presentation. So thank you all for joining us today, and have a fantastic rest of your International Day of Older Persons and Canada's Seniors Day. Thanks, everybody.